Hello, and thank you for joining this Specialty Pharmacy Times Practice Pearls titled Best Practices for Dispensing Multiple Myeloma Medications. With a plethora of FDA-approved regimens for the treatment of multiple myeloma, a personalized approach is the key to obtaining deeper and more durable responses for both newly diagnosed disease and in the relapsed setting. Some of the newer agents are oral medications, adding to the patient's quality of life. With the multiple steps involved, with obtaining prior authorization, with a limited number of pharmacies allowed to fill these specific agents, it's important to identify the challenges and to discover best practice processes to get the medications into the patient's hands quickly to ensure therapy is not impacted. I'm Dr. Peter Salgo. I'm a professor of medicine and anesthesiology at Columbia University College of Physicians and Surgeons and an associate director of surgical intensive care at New York Presbyterian Hospital. That's a mouthful. Joining me for this panel discussion are Cheryl Allen, Vice President of Industry Relations at Diplomat, and Dr. Noah Baran, attending physician and medical oncologist at the Myeloma Division of the John Theurer Cancer Center in Hackensack, New Jersey. Thank you both so much for joining us. We're going to be talking about multiple myeloma. Why don't we set the table a little bit? How big a problem is it? How many people have it? What are we talking about?
So multiple myeloma is the second most common hematologic malignancy, second to non-Hodgkin's lymphoma, which is actually about 100 different cancers. So really it's the most common hematologic malignancy. It's actually a rare disease. There's only about 100,000 folks in the United States with it.
Is that right?
30,000 or so newly diagnosed cases per year.
You know, from the way it's discussed in medical school, and the number of cases that I've seen at Columbia, which is a tertiary coordinated care center, you'd expect it to be a lot more common than that, but it's not. So why are we having this conversation?
I think, the impact on the healthcare system, we talked a little bit about the cost. We know that just oncology in general, about $133 billion globally, the US, where about $50 billion of that. It's estimated that by 2020, the global spend will be $200 billion, and then the U.S. Will be responsible for about $100 billion.
When we're talking billions here, you're either talking government money, I mean, the kind of money that you see in the newspapers for CEOs of tech startups. Do we know how many of these billions are related to myeloma as opposed to other cancers, or we don't know that?
So the therapies for myeloma are so rapidly changing. Just in 2015, we had 5 new drugs approved, and the market is becoming saturated. And from what I understand, the cost of myeloma therapies is the second highest of all cancers.
But it's
despite the fact that it is
rare.
One of the most rare
Why?
cancers.
Is it that the drugs are expensive, or you need a lot of them? What?
The drugs are very expensive. So to your point, the recent oral oncolytics that have come to market, the cost of those is about $150,000 per patient annually. So when we talk about global spend in oncology being, in the billions, it's the top 35 drugs across the space that's driving
All right. that spend. And of the money we're spending on multiple myeloma, what % do you think is spent on the therapeutics, on the pharmaceuticals, as opposed to the rest of the therapy?
I think that to answer that question, you have to understand the disease. And multiple myeloma is a chronic disease. Patients now, it used to be that life expectancy was 3 to 5 years. Now, patients are living for decades, for the most part, standard risk patients. So therapy is chronic, and these patients are on treatment for the almost entirety of their life, from diagnosis until death. There are areas of time, periods of time where they're not on therapy, but they're on triplet regimens. For upfront induction therapy, they get a triplet therapy from anywhere from 2 to 8 months. Then they may or may not get a transplant. Then they may or may not receive maintenance therapy, which is an oral oncolytic, and then once their disease relapses, they are on line after line of triplet therapies.
So every time you opened your mouth, I heard ka-ching, ka-ching, ka-ching. It's expensive. It's be careful what you wish for, because yes, we're going to extend people out. It's true for many diseases, but the cost of doing that is real. How much of that cost now is oral oncolytics as opposed to IV? Do we know?
I think what we're seeing, and not really quoting anything, but we're seeing an erosion of the dollars, the top line dollars in the infused oncolytic space, because we're seeing some generic and biosimilar erosion, and we're expecting more of that to come as these biosimilars come to market. Now, true, we've had a lot of legal action in the space so that some of the biosimilars aren't getting to market, and even the list price isn't what we would have had expected them to be. But ultimately, we'll see the costs come down.
But what I'm trying to parse out here is we have the IVs and we have the oral oncolytics. The oral oncolytics, I'm assuming, are newer, tend to be on patent, tend to be more expensive. What % of the total burden of the pharmaceutical cost, can we get an estimate on this, is the oral?
I
the
think
oral limb?
it's more than 80%.
So, I think that's what you were referring to also.
Yeah.
The IVs are already out
The
there.
cost driver is definitely in the branded oral oncolytic space.
Okay.